Hello, everyone. I'm Madeline Milka, President and CEO of APAICS, the Asian Pacific American Institute for Congressional Studies. Welcome to the 2025 APAICS Health Summit. The APAICS Health Summit brings together nonprofit and corporate leaders, subject matter experts, and local and federally elected officials for health policy discussions that affect the Asian American, Native Hawaiian, and Pacific Islander, or AA and NHPI, community and the nation at large. I'd like to thank our summit partners, Adtalem, Amgen, AstraZeneca, Biogen, Blue Cross Blue Shield, Catholic Health Association of the United States, Compassion and Choices, Pharma, and Planned Parenthood. Your support enables APAICS to fulfill its mission of promoting AA and NHPI participation and representation at all levels of the political process, from community service to elected office. Over the next 2 days, we'll talk about mental health, the impact of the Affordable Care Act after 15 years, the importance of disaggregated health data, the role of AI and emerging technologies in healthcare, and what our partners are doing to adapt to changing conditions in the healthcare industry and to better serve our community. I would now like to give a warm welcome to KPAC Executive Member Congresswoman Pramila Jayapal, representing Washington's 7th District. She is the first South Asian American woman elected to the U.S. House of Representatives and one of only 24 naturalized citizens currently serving in the United States Congress. Prior to her work in elected office, Congresswoman Jayapal spent almost a decade working on global health and development. Please give Congresswoman Jayapal a warm welcome.
I'm Congresswoman Pramila Jayapal, and I'm honored to represent Washington's 7th Congressional District in the House of Representatives. Thank you all so much for inviting me to share a few words today about AA-NHPI health and what we can do to close the gaps in health research and healthcare sectors. When I became the first South Asian woman ever elected to the House of Representatives, I knew that I had the responsibility of bringing the perspectives and the experiences of my community with me to Congress to try to make a change. Those perspectives and experiences led to me introducing the South Asian Heart Health Awareness and Research Act, legislation to both raise awareness about the alarming rate of heart disease for South Asians in the U.S. and also put resources toward reversing this trend. Research that will help not only South Asians, but all Americans. No community should face disproportionate health outcomes because of a lack of research, understanding, or awareness. There are steps we can take to right these wrongs and ensure that everyone has a fair shot at living a happy, healthy life. As I call for in my South Asian Heart Health Bill, we need to put more effort toward data disaggregation in medical research. My legislation would provide grants and resources for data on AA-NHPIs to be broken down into further subgroups rather than the broad AA-NHPI group. Not every person from the AA-NHPI community is the same, and not every one of us has the same health needs. Without disaggregation, critical research findings are often hidden in larger data trends, and they hamper drug development and treatment. We also need to remove barriers and build trust to promote AA-NHPI people and other people of color participating in clinical trials. Our health research system has to take more care to focus on these details so that we can give all members of our community better tools to manage their health and achieve positive outcomes. More broadly, we need to continue to fight for universal health care, where the focus is on people, not profits, where everyone can get the care they need whenever and wherever they need it without incurring debt, where our grandmas and our aunties don't have to cut their prescription pills in half at the dining room table because they simply cannot afford the high price of necessary medications in this country. What we know is that lack of access to healthcare, high prices, and medical debt disproportionately affect communities of color, including our AA-NHPI communities. Our work together to ensure that everybody is in and nobody is out is so important. So thank you all for taking part in this discussion today. Having these conversations is important in ensuring that our advocacy efforts are focused where they can have the greatest impact. As you all keep doing this vital work, I'll be right alongside you in Congress, working to pass legislation, secure funding, and lift up AA-NHPI voices fighting health disparities across America.
It's my pleasure to introduce Congresswoman Amata Radewagen, representing American Samoa. Congresswoman Radewagen is the first woman elected to represent American Samoa in Congress. She works to advocate for improved healthcare access and programs that address the health issues that disproportionately affect Pacific Islanders. Please welcome Congresswoman Radewagen to the Health Summit.
Ta'alofa lava. I appreciate the opportunity to send my greetings and warm wishes for a successful event. I represent American Samoa, the U.S. territory in the tropics south of the equator. For everyone who knows the long trip from here to Hawaii, we are another 5-hour flight south of there, right before the international date line. One of our biggest concerns is having the best possible health care for our people. Our largest island, Tutuila, has our territory's only hospital, named for LBJ because that's how long ago it was built. Beyond the aging facilities are the challenges of getting the latest medical equipment and attracting and keeping doctors and specialists to serve a small population. We're blessed to have some wonderful, dedicated doctors and nurses, but medical professionals at all levels can make much more in a U.S. city, and that's a fact we really can't alter, so we have to find other ways to improve. Our island's economic and geographic challenges there in the South Pacific would make a case study of these healthcare conditions, but the problems are relatable. Many of you hear similar descriptions from rural, remote, or otherwise underserved communities. That means we're not alone. It also means the need is widespread and more challenging to solve in all these places. While we can never stop working for facility improvements and attracting great people, the most realistic solution at hand involves telehealth. New technologies have opened new doors. In theory, doctors in small South Pacific islands can access the leading expert on any subject and get direct insight on camera. The challenge is making that a reality, which requires equipment, training, systems, and public, private, and academic cooperation. I'd wager that you have some experts on telehealth in the room, and I would say to anyone in the industry, first, that you not forget the distant territories, and secondly, that my office door is open to hear of the best in ideas and bipartisan legislation that focuses on these areas. I'm sure this summit will include some of those exact concepts, how to turn dreams of widespread access to the best health care into practical possibilities in the near future. So thank you for those efforts and ensuring our Asian American and Pacific Islander American communities are remembered and supported. I also serve as Vice Chairman of the Veterans Affairs Committee and have a large percentage of Pacific Islander veterans in my district, as do other Pacific territories and freely associated states. A recurring topic in our committee is how mental health services are a growing need both for veterans and the population at large. As we step up efforts to serve and support these needs, improve the conversation, and reduce stigma, we also need to focus on root causes and prevention of these health needs when possible. When it comes to legislation, we won't always see agreement in everything, but these goals are certainly a starting point of bipartisan consensus. Most people in public service have good motivations. We work together where we agree, take a stand if we disagree, but should still be friends and optimists about our country. The biggest reason for my optimism is from our many motivated Asian and Pacific Islander American young people. I routinely have brilliant young Pacific Islanders as interns in my office with big plans for graduate school and careers. including public policy and healthcare, so I know our future is bright. Thank you. God bless your summit. Soifua Maia Manuia.
Our next panel, Tackling Challenges and Achieving Health Outcomes, will address the high prevalence of some chronic diseases among AA and NHPI communities and the lack of research funding to address these disparities. I'm pleased to introduce our moderator, Dr. Jenifer Velotta, a Bay Area native thoracic surgeon and researcher dedicated to improving lung cancer screening among Asian Americans. He received the 2023 Thoracic Surgery Foundation's AstraZeneca Reversing Health Disparities in Lung Cancer Research Award for his groundbreaking work on increasing lung cancer screening in Asian American populations. Please give a warm welcome to our moderator and our panelists.
Thank you, everybody, for joining us today. We're here to talk about health equity, health outcomes in the Asian American, Native Hawaiian, Pacific Islander community. My name is Jeff Velotta. I'm a thoracic surgeon at Kaiser in Northern California and work specifically a lot on lung outcomes, but specifically lung cancer screening, lung cancer survival in Asian Americans specifically, and disaggregated by different Asian American groups. So very excited to have our illustrious panelists on, and I'll just introduce them briefly, and then they'll have a segment to each speak about themselves and their organization. But first we'll have Shushama Alam. She is the Global Medical Director over at Amgen. She'll be speaking first. Second, we have Adam Carbullido, Director of Policy and Advocacy for the Association of Asian Pacific Community Health Organizations, otherwise known as APAICSO. Next, we have Liam Lee, who is the Senior Director of U.S. Oncology Medical Diagnostics at AstraZeneca. And then we have Dr. Representative Megan Srinivas, who is Iowa State Legislature, as well as an infectious disease doctor. And last but not least, we have Jenifer Waldrop, who is the Executive Director of the Rare Disease Diversity Coalition. So thank you for everybody for being here. First, I'm going to start off with Shu Alam, again from Amgen. Why don't you tell us a little bit about yourself first and a little bit more about your organization, and then we can dive into what your thoughts are on some of the health inequities or equities that AAPI individuals face with regards to health outcomes and how you hope to alleviate that through Amgen.
So my name is Shushama Alam, and I'm a medical director for external engagement at Amgen. And so honored to be here with these group of experts when it comes to sharing insights and really meaningful solutions around health equity. And we know that health disparities is a critical issue here in the United States and globally, and that there are certain disease states, including cardiovascular disease, that disproportionately impacts populations. And that includes Asian Americans, Native Hawaiians, and Pacific Islanders. And so as part of my role and really Amgen's focus, it's thinking of ways in how can we remove barriers when it comes to access to equitable healthcare, and look forward to the discussion today to be had around, how can we drive change across healthcare disparities.
Okay, thank you so much, Shu. Okay, next we'll go to Adam. Why don't you go ahead and introduce yourself? Hi, Adam.
Hi, Jeffrey, and thanks everyone for joining the discussion today for this important topic. I'm Adam Carbullido, the Director of Policy and Advocacy with the Association of Asian Pacific Community Health Organizations, or APAICSO for short. We're a mostly community-based healthcare organizations, primarily federally qualified health centers that serve Asian Americans, Native Hawaiians, and Pacific Islanders in the United States, the U.S. territories, and the freely associated states. APAICSO members provide primary, dental, and behavioral health care to nearly 750,000 individuals every year. And we do so in ways that really speak to an individual's language and culture, knowing that the Asian American, Native Hawaiian, and Pacific Islander communities are very diverse, coming from 50 different countries, speaking more than 100 different languages. We know that ensuring access to care really means meeting patients where they are. And I'm looking forward to the discussion today to discuss what are some of the challenges affecting our communities and how we can address them across the nation. Thank you.
Thank you, Adam. Next, we have Liam Lee from AstraZeneca. Hey, Liam.
So hi, my name is Liam Lee. It's a pleasure to be here today speaking with all of you. I'm currently serving as a Senior Director of U.S. Medical Diagnostics at AstraZeneca, which is a leading multinational biopharma company. on diagnostics for lung cancer patients, and it covers screening and early detection to biomarker identification for treatment selection and monitoring. But in everything that I do and I oversee at AstraZeneca, I aim to deliver medical advancements that benefit individuals of all races and ethnicities. And this can only really be achieved by recognizing and tackling disparities head on, including those experienced by Asian Americans, Native Hawaiians, and Pacific Islanders. So excited to be here, and I'm hoping that we will have a very productive and exciting conversation here today.
Great. Thank you, Liam. And next we have Dr. Srinivas, Representative Megan Srinivas from Iowa. If you could go ahead and introduce yourself, that'd be great. Thank you.
Hey, everyone. Great to be here with you all today. My name is Megan Srinivas. I'm an infectious disease physician in my everyday life, and it was really my work looking at low resource settings, especially in rural environments, both globally as well as domestically, that led me to want to run for office. And so now I serve in the legislature, trying to be a voice for my patients and changing the systems in which we all function to improve health equity for everyone.
Last but not least, we have Jenifer Waldrop from Rare Diseases.
Thanks for having me here today. I'm excited to be a part of this esteemed panel. What a great set of introductions. So as mentioned, I'm Jenifer Waldrop, the Executive Director for a coalition called the Rare Disease Diversity Coalition. We're part of an organization called the Black Women's Health Imperative. This coalition was started almost 5 years ago now because we recognized that there were no other organizations out there that were umbrella organizations, hyper-focused in health equity, and that's our sweet spot. So as an organization that's really focused on rare diseases and health equity, we're looking to narrow the gaps and issues on the diversity components and the disparities that happen in the health community here for the rare disease patients. I look forward to today's conversation and learning from you all today.
So Jenifer, we'll start with you. So when you talk about Rare Disease Coalition, this is really interesting to me as a physician too, and what overall are your thoughts? Because me, even as again, I'm a thoracic surgeon, so very specialized, but it's not something that I think about as an Asian American individual myself. I'm Japanese American, but it's not something that I think about for rare diseases and how does that really relate to the AANHPI community differently, or how is kind of your work on that involved with that, or what? I guess what I'm getting at is, like a very basic question, do Asians actually have rare disease issues, and is there health inequity in that, or is it all equitable for Asians with rare diseases? It's somebody, for me as a layperson, I have really no idea actually. So I'd be interested to hear your thoughts.
So rare diseases is a category that we have created as scientists around the world. And the definition actually varies, right, in different countries. People that live with rare diseases, and if you are so fortunate, because 50% of rare disease patients, unfortunately, are children, and those children can either be born with a rare disease and never see day 2 of their life, or they could, live into adulthood with the rare disease. So there is a lot of complexity when it comes to rare diseases, but I don't want us to think that if somebody has a chronic disease, there's no way that it could be a rare disease. No, they can be living with a rare disease. A few rare diseases that you may have heard of that does impact the Asian community, for example, would be sickle cell. So many folks feel like sickle cell is a rare disease that only happens to African Americans or the African population. That is actually not true. Folks that are along the equator line, India, for example, Pakistan, places along those areas actually have a pretty high rate of sickle cell in that community, because sickle cell is a reaction to essentially malaria and those that have a lot of mosquitoes in those countries. So sickle cell is one that's pretty common in the Asian community. Another one specifically that if you think about it, you may not know about it, it impacts actually your kidneys. So there is a kidney disease called IgA nephropathy, IgAN for short. That's also known as Berger's disease. It is a rare chronic kidney disease, but unfortunately, it does disproportionately affect the Asian population. And the reason why many on this call today or others that are listening in may not know about this disease is because, quite frankly, there's underrepresentation in genetic research and, of course, disparities in the healthcare access for many Asians. So they may experience, as you mentioned, being a specialist, there are not that many specialists in these areas. So geographically, that is challenging. They could have delays in diagnosis, they could have misdiagnosis, or they could have inadequate treatments along the way. So when it comes to rare diseases, these patients are really, really unique because of the symptoms that they experience, the specialists that they're exposed to. And we know with the Asian populations, they're not just found on the East Coast and the West Coast, they're all around the country. So how are they getting access to what they need based on their actual physical geography? So I'll just pause right there to hopefully that answers your question.
Are you kidding me? I think we all learned something, tons. But so you know where I'm going with this with the follow-up question, right? You obviously noted India, Pakistan, but what specifically do you think that the Rare Diseases Diversity Coalition in your group is helping with that? Are we sending aid? Are we getting better sickle cell diagnostics? Is it financial? Is it legislation? Is it kind of, how do you feel that your group is kind of helping, or, through education or whatnot?
We are actually made up of 3 working groups, and basically along the lines of what you just mentioned. One of our working groups is on research and clinical trials, and we want to have more diversity, obviously, in the United States with research and clinical trials. That working group actually has done a few papers. We've partnered with the Rare Disease Clinical Research Network, otherwise known as RDCRN, which is a part of the NIH, the National Institute of Health here in the United States. And that a number of folks, the PIs, the doctors, researchers, as a part of that network, we looked at the last 20 years of data that the NIH released to us so that we can analyze what is the diversity, what is the race and ethnicity, essentially, of these populations in the rare disease space when it comes to clinical research. That publication is being out at journals right now, and so we're waiting for that to be picked up. So I can't reveal too much of it. But as you can imagine, we don't have a lot of Asian populations that is a part of that data. We're filling in the gaps so that there's a baseline. When organizations like AstraZeneca and Amgen say, we need more diversity in some of our research and clinical trials, well, guess what? What's the baseline for some of this work? And so, that's what we're trying to do, is to help with some of the information that's lacking out there, so that then you can go back and share a little bit about where we need to go from there. Because if you don't know where you are today, you can't figure out where you're going to go tomorrow. Megan seems to agree with that. So thank you, Megan. And so the other thing I would also say is, yes, we also have a policy and legislation component to our working group. That working group, for example, has been working really hard on a rare disease legislation for the last few years. And finally, on Rare Disease Day, which is always the last day of February, Representative Marilyn Strickland out of Washington has put forward to the House that she's going to sponsor what's called the HERD Act. It's called the Health Equity and Rare Disease Act. And so that act now is on congress.gov. So it has a bill, which is 1750. And one of the things that we talk about is rural populations in that, so that we can have better access to rural populations. There are some incentives in there for doctors to do more in the rare disease space. We're doubling down and helping out with the Native Americans get access to clinical trials, for example. So it's a multifaceted act with different components to it. This just went live last week, or the last month, I should say. And then that's our policy and working group. And of course, we've got great relationships with the Rare Disease Caucus out there. The third group is the patient, which is the center of everything that we do. The patient, the provider, the caregiver journey working group. That working group put together an amazing report regarding the survey that we pulled together, getting the voices of patients and caregivers from the historically underrepresented populations. So we hit almost 50% of what we would call the DE&I population, essentially, rural population, LGBTQ, folks from the race and ethnicity areas. So when we define diversity, it's pretty broad in scope. And we're the first organization to be able to work with the organization NORD, which is the National Organization for Rare Disorders. They're the ones responsible for the Orphan Drug Act. They're the ones that actually helped us define here in the United States that rare diseases are defined as those that have, the disease itself has fewer than 200,000 people affected in the United States. So we put together this amazing survey. We're able to analyze the survey, and now we have that report available on our website, both in English and in Spanish. So that's one of the projects that the Patient Provider Caregiver Journey Working Group has done. And lots of organizations, lots of representatives are using that as part of their data. And the other thing that we're also doing is one of our signature programs is our fellowship. So Dr. Velotta, when you were in school, you may have had rare diseases as an elective, and you may or may not have taken that class. But if you, as you may recall, rare disease topic with 10,000 rare diseases, you can't get through everything. So we have a fellowship program that allows you to dive a little bit deeper into the rare disease community, patient advocacy organizations, and different educational modules. And we partner with one of our coalition members, because we're made up of coalition members, to actually host the fellow as well. So the fellow gets some real particular projects that they're working with, and they also continue to learn and dive deeper into the medicine and into the science. So those are a couple of things that we do that we're trying to make an impact and hopefully a systemic impact in the rare disease community.
Fantastic. No, that's amazing, Jenifer, what your group is doing. So thank you so much for enlightening all of us. It's a perfect segue to Dr. and Representative Srinivas to elaborate a little bit more on her take on being a doctor, being a physician, but also being involved in legislation and how we can affect legislation, because that's something that most of us doctors can't do. But Dr. Srinivas may have a very good idea of how we can help from what we know with her vaccines and distributions and underserved AAPI community. But if you can kind of elaborate on the legislation part of what really that means and how you can make a difference or how we can make a difference.
Yeah, I have to say, I mean, Jenifer, so much of what you're saying, I feel like we could just have a conversation for an hour alone. There's so much overlap between what you're talking about and the work that we do every day on the ground, both being the Asian that you're talking about that lives not on the East or West Coast, but in the middle of America and in a rural setting. So I completely understand a lot of what you're referring to. So to get what you're alluding to, Jeffrey, about really how we can impact legislation, even from not being at the table yourself. Advocacy. Advocacy actually makes such a huge difference when it comes to state legislatures. Even at the national level, it makes a huge difference. But at the state level, you have a much larger voice because these people are often your neighbors, they're your community members, they see you at the grocery store. So it's really hard to avoid their opinion or the opinion of your constituents when these are people you live with every single day. You're not far away from them. You see how their life is impacted. And so when you're having those day-to-day conversations, feel free to call up your legislator, send them an email. There are bills that have been created because one person sent an email and it made sense. There are bills that have been stopped because we were able to mobilize 30 people to send an email to their legislator. And that was enough to stop it. Your voice actually matters because a lot of people don't take the time to do that. And so there is a lot of collaborations that I do with both different stakeholders, including industry such as Jenifer and Shu, but then also with our patients, with our hospital systems, our physicians. And I mean, even talking to some of the things that you were discussing, Jenifer, a lot of my past research has actually informed some of the directions in which I have taken legislation since I've taken this position as well.
Fantastic. In specifics, you don't have to be too specific, but in certain things with relationship, because I do think it's interesting for our viewers, listeners, even myself, I'm in California, and a lot of us, you're like you said, alluded to West, East Coast, we're biased by that. What we see in Iowa specifically, that especially when it comes to the Asian American, Native Hawaiian, Pacific Islander community, like actually me, I feel bad. I don't know that community that well in the Midwest, but how does that relate to you being in Iowa? Is there differences, or is it the same in middle of America that Asians all face, or is there different disparities that we may see in terms of what you see from health equity standpoint?
There are differences, of course. I mean, just the geographic aspect of it creates a whole new layer of inequities when it comes to rural versus urban dynamics and what's even available resource-wise. But there are also so many similarities. For instance, when we're talking about the NPHI or NHPI, community, we're looking at a community, as Jenifer alluded to, that has often been excluded from trials, that have been excluded from what we consider the normal standards of care when we're looking at lab measurements, when we're looking at how a treatment affects people. And that is something that impacts everybody throughout the United States, regardless of whether you're on the East, the West Coast, or in the middle of the country. And helping to get more data that is actually relevant to our communities and our identities is so key to enabling us to get better access to healthcare regardless of your location. And so to that effect, one of the big projects I actually worked on during the pandemic as an infectious disease doctor, I was very active during that time, was we partnered, I was on faculty at UNC at the time, University of North Carolina in Chapel Hill prior to being elected. And we really worked on, for our trial recruitment, creating innovative ways in which we could have culturally tailored outreach to expand who was in our study population. Because only if we expand that and do it in unique ways that we haven't tried before, are we able to actually have more representative data so we can apply it to the broader swath of our community. Another effort that I've been doing is, and actually I was able to get this bill passed last year, is a biomarker bill. And I know a couple of you have mentioned biomarkers when we were doing our introductions. So a biomarker, for those who are not familiar, is basically a way to do a lab test that looks at your blood. And we can look at different types of markers for cancer, for Alzheimer's, for different types of disease. As an infectious disease doctor, I look at other markers that try to tell me, hey, are you entering sepsis or not? Unfortunately, we have a very limited set of what is approved for coverage for insurance. And a lot of that is once again based on who has traditionally been studied. And we use their normal values to have to then be able to be approved to have those biomarkers covered by insurance. So last year we wrote a bill and got it passed all the way through and signed into law by the governor that actually mandates coverage for any biomarker test that can be proven to be evidence-based in either helping with prevention, diagnosis, or treatment. And so it opened up the door for physicians to really tailor their care to each individual patient and not be restricted by oftentimes prior authorizations that prevent us from getting the more expanded level of care we need for study populations that have not been included typically before.
Oh, no, that's fantastic. You're singing right up the right alley, right, with biomarkers. A lot of us on this call, right, understand that whatever field you may be in. So that's really fantastic. And that really helps me and I'm sure the audience out. So we have Liam Lee from AstraZeneca. And so Liam, what are your thoughts from overall perspective? Asian American, Native Hawaiian, Pacific Islander. Let's get into it a little bit more. Maybe some health inequities or different disparities that you may see in this population that AstraZeneca may see or is kind of focused on and how you're combating that.
Thanks, Jeff. Well, as an Asian American myself, I know that we have many health disparities, but that takes about a week to really talk through. So instead, I'm going to really focus on cancer because we have the unfortunate distinction of being the first and only U.S. population subgroup to have cancer as a leading cause of death, right? No other populations had this before. And Asian Americans don't just have higher incidence of cancers. I think that's a misperception we have sometimes about liver and stomach cancer. And for instance, we do have higher incidence in those areas, but it's not just about higher incidence. It's also about specific gaps that are really rooted to our background as a community, right? So if you think about our Asian American community overall, majority of the cancer cases really happen in older patients. And our older Asian American community, about 86% apparently, and this number surprised me, so I wrote that down, is actually born outside of the US, right? And because of that, their native language is different. And a third of us actually have low English proficiency, right? Even those who might have better English proficiency than low may not have the expertise or fluency required to really have tough medical discussions, but especially when you're talking about serious diseases like cancer. And then add on to that, you have the unfamiliarity with the Western healthcare systems and the cultural differences in terms of how you communicate difficult issues. Our elderly in the community just have difficult times following doctors' instructions or even really understanding them in a way that resonates with them, right? For instance, my mother, she's been in the US for decades now, and she still wants to find a Korean doctor whenever she wants to have a medical exam. It doesn't matter what the issue is, she'll still look for that. So overall, we have this cultural and language issues, as well as different understanding of the, I guess, gravity of some of the diseases that you can think about. And that leads to the lowest satisfaction rate among cancer care coordination in the different racial subgroups that we have in the US. And that's a really unique problem. So it's not just we have more incidents, it's also that we have a fundamental difference in that area. And then because of the similar issues that I just talked about, Asian Americans also have the lowest cancer screening rate. And this is something that Jeff and I are quite passionate about as well, in that we have a lot of Asian American patients who are not opting into cancer screening protocols, and thus are diagnosed at later stages of cancer compared to other racial groups. And this is also critical because survival rates drop significantly at each stage of cancer. So it's not just about awareness, though. I want to also pause there because we have a US representative here. I do want to also say that the policy may also need to get updated to reflect Asian American biology aspect, right? So if you think about it, lung cancer overall, as an example, you have about 10% of the lung cancer cases in the US are from non-smokers. But when you look at just the Asian American community, it's about 30 to 40% of the Asian population who have lung cancer are never smokers. And then if you look at Asian women alone, that number goes up to about 50 to 60% who are never smokers. And when we look at USPSTF guideline for lung cancer screening, it specifies 20 pack year smoking history. So for Asian Americans, what's out there right now, doesn't really cover most of our population when we're thinking about Asian American women, right? So this is something that we also have to address directly because there are some underlying genetic factors, right? We have different ancestries, and because of that, we have different underlying genetic factors. For instance, Asian women who never smoked and have lung cancer have a higher rate in mutation in EGFR gene, for instance, right? So we have to be able to address fundamental differences that are not captured in some of the screening guidelines provided by the US government right now. So in short, many, many gaps. And I think I highlighted on many gaps on lung cancer alone. But there's a lot of work that we can actually do together. And I'll wait for the next section with Jeff to touch on some of the solutions.
We're seeing from the group a commonality theme of representation, whether it's in trials or just real world data of getting Asians on the table so we can study them just at their baseline. So then we can decide whether it's rare disease, vaccines, infectious disease, lung cancer. So then they can relate because as you alluded to, Liam, the two major lung cancer screening trials that were based on the 50 to 80 age and 20-pack year smoking history or current smoker, again, is based on mostly white men. In fact, one of the studies was done, basically majority was done in Europe, where, as you can imagine, not many Asian American, African American, or Latin. So obviously from the policy side, that needs to change. But first, we need to start with what you guys are talking about, just representation of getting the data on all these Asian American subgroups. So I really see that commonality. But so Adam from APAICSO, wanted to just let you discuss a little bit about your organization.
Yeah, thanks, Jeff. I think that's a really important question. But before I get into that, first, I do want to acknowledge that we have made a lot of progress over the last 15 years or so since the passage of the Affordable Care Act in addressing health disparities and health challenges for the Asian American, Native Hawaiian, and Pacific Islander communities and the nation at large. The ACA and a lot of the successive legislation since has really led to the largest decrease in uninsurance rates in the country. And for our communities in particular, Asian American uninsurance rates are at an all-time low at 7%, and uninsurance rates among Native Hawaiians and Pacific Islanders are at 11%. Obviously, when you get into the subcategories within each of these communities, it can be a little bit different. But I do want to acknowledge that. And a large portion and a large reason why that has been successful is because of the expansion of coverage through both the private insurance marketplace as well as through public insurance such as Medicaid and Medicaid expansion across the country. That being said, there are a lot of barriers affecting our communities. First, as I think has been largely acknowledged by my other fellow panelists, data is a huge challenge for our communities, particularly in getting granular level data on the subpopulation groups for our communities. Asian Americans, Native Hawaiians, and Pacific Islanders, we're not a monolith. As I mentioned earlier, there are more than 50 ethnicities within our communities, and each one of our communities comes with their own unique challenges or their own unique experiences and differences in how they experience medicine and healthcare in the United States. So if we could get better data on our communities, disaggregated at that granular level, it would make a huge difference. And a lot of that starts from how guidelines are set by the federal government. Last year, the Office of Management and Budget did release revisions to how the federal government will be collecting disaggregated data for our communities. A lot of it was tailored to how is it that we're collecting subgranular level data for Asian Americans and Native Hawaiians and Pacific Islanders. Right now, the federal agencies are in a implementation drafting phase on how they're going to implement the revisions to SPD 15. But it'll make a huge difference across the board in better understanding our communities, whether it's through CDC surveillance data, whether it's through various disease-specific data that is collected. The more that we know at a granular level, the better we're able to target interventions and treatment options. So we do hope that we'll see that process move forward, and that being adopted by the various states, cities, localities across the nation. Second, as has also been touched upon, is the importance of language access and ensuring that patients and individuals have access to care in a language that they can understand. We saw through COVID that when individuals aren't communicated in a language that they can understand, it leads to worse health outcomes. It leads to them not being able to understand the procedures that they are going to be undertaking. It makes it so that they just don't understand what are the treatment options, or what is it that their doctors are prescribing to them. And that causes a huge challenge across the board. Thankfully, there have been movement in this regard. Like I said, the Affordable Care Act, Section 1557, known as the Healthcare Rights Law, that mandates language access to every patient that walks into a medical provider's doors. Obviously, there have been challenges along the way, but we need to uplift those legal processes and ensure that they're protected so that when individuals go into a healthcare setting, that they do get services in a language that they can understand. Third is within our communities. Obviously, many Asian Americans and Pacific Islanders are immigrants to this country. About a quarter of the Asian American community are non-citizens. 1 in 6 Pacific Islanders are non-citizens in the U.S. So the access to healthcare and other support programs is absolutely vital to our communities, and ensuring that when an individual needs assistance, whether it's through Medicaid, through SNAP, or through housing assistance, that they're able to get that, because we all know that healthcare is affected by the social determinants, the social drivers of health, and these non-healthcare related things that contribute to healthcare. So we need to ensure that our communities have the full wraparound of getting the benefits and the services that they need. And lastly, one particular barrier within our communities that APAICSO members have seen is the unfortunate increase in anti-Asian hate and Native Hawaiian and Pacific Islander discrimination throughout this country. It has been through this that many of our communities have felt victimized, and we've seen a large drop in patients seeking care, and that has led to worse health outcomes. It leads to providers having to spend more time and resources reaching out to patients and trying to get them into the clinic so that they get the care and the services that they provide. And it has also just led to the sense of othering within our communities, and we know that rise in discrimination and hate also leads to worse health outcomes. And all of this, I know that you wanted me to focus on funding, and maybe I can touch about that in the next section. But I really think that those are the underlying things that APAICSO has seen at a community level. And we are working actively both at the community level, the state level, and at the federal level to try to address them and ensure that we're making progress on all those points. Thank you.
No, that's great, Adam. Thank you so much. All right. So Shu, thank you for being patient, and welcome your thoughts and your thoughts on Amgen and overall what with health equities in Asian American, Native Hawaiian, Pacific Islanders.
Thanks so much. No, thanks all. So this has been just an incredible, I think, engagement, and can apply so much of, I think, these learnings with what I'll speak about as well. So as I shared, I know my focus is cardiovascular disease, and just to sort of shed a light on just the fact that cardiovascular disease, heart disease, it continues to be, one of the leading public health crises in the United States, and really has been for the last 50 years. So just to give a little bit of perspective around, cardiovascular events like a heart attack, like every 40 seconds in the US, someone is experiencing a heart attack. And like I shared too, disproportionately, there are populations like Asian Americans, Native Hawaiians, Pacific Islander communities that are at just inherently a higher risk of cardiovascular disease. And so heart disease sort of encompasses a couple of different conditions, as you know, Dr. Velotta, Dr. Srinivas, and others. But one of the major drivers, main culprit when it comes to a CV event, like a heart attack or stroke, is having very high LDL cholesterol, commonly referred to as bad cholesterol. And so when LDL builds up or accumulates, and someone has elevated LDL, it can build up in the blood vessels called plaque, and that can then narrow the artery walls, obstruct blood flow, and lead to what could be a heart attack or stroke. And there are communities like South Asians, myself, where like South Asian men, 30% have elevated LDL, South Asian women, close to 20%, yet like don't even know that they have high LDL or even know what LDL-C is. Like my parents, I think just, not even realizing what is LDL and that they themselves are at this heightened cardiovascular risk. And so we know that there is this persisting gap in public awareness around the dangers of elevated LDL, and that despite this prevalence of communities like Asian Americans having higher CV risk, they are still less likely to receive timely cholesterol tests, and that's due to a couple of different reasons. Like Liam, I think, spoke to this too, like just cultural differences, language barriers, just not being able to even like get to the clinician or PCP themselves, and then also just limitations in the healthcare space with healthcare disparities, having that access to effective care. On the policy side of things, and so great to see Dr. Srinivas here too. I think there are barriers from the policy standpoint when it comes to first step therapy protocols. So step edits that are in place that can actually limit a patient from getting the medication that they were prescribed by their clinician because they're mandated to try another medication first from their insurer. And that then can prolong that patient to cardiovascular risk exposure, potentially put them at risk for side effects from other medications. And then on the, secondly, in parallel, which we all know, prior authorizations and PAs are, we know are also onerous when it comes to paperwork. It can lead to delays, rejections, again, causing challenges when it comes to timely, effective care. And so all this to say that I think, it is so important when we think about our communities and around, I think, going back to CV risk and even other disease states. I mean, what's something simple you can do? And when it comes to cardiovascular disease and LDL-C, the first step is honestly like getting tested. It's just getting that cholesterol test done. That's the first and easiest way to really inform a patient person that, know your number and then follow up with your clinician, your PCP, whoever, and just understand what that number means and take actionable next steps. And so, LDL-C is really one of the easiest modifiable risk factors, in fact, in controlling cardiovascular risk. And so, look forward to sharing a little bit more of the solutions around this, but, thanks to the team here, just sharing that here.
Thank you, Shushama. I wanted to hear from each of your groups if you guys are directly affected by funding budget shortages. And if you are, how are we tackling that, right? Especially when we know that the AA-NHPI community is already underfunded, already under-recognized, and then you take away all stuff like it's been going on, or I'm being over dramatic, but like how does each of you combat that? So I kind of like, so Shu, I'll start that with you. How does Amgen think about that? Or is it not an issue? Maybe it's not an issue where there's plenty of funding, especially for the Asians, and we're in a heyday where this is like the most fantastic period. But in my opinion, we may not be. But so how are we fighting that? How are we battling that?
So I'll just speak to Amgen in terms of Dr. Srinivas. I think you spoke to it first on the clinical trials piece, where there are dedicated teams in place. For example, at Amgen, the acronym is called RISE, Representation and Clinical Research, that is dedicated to, in the company's clinical trial portfolio, ensuring that there is diversity within the protocol from the start. And that allows then to really ensure that the patients that are usually underrepresented are reflected in the studies, because those are the patients that Amgen seeks to serve. And then thinking of other simplistic ways of like, how can we ensure that we close the gaps from the CV disease perspective around LDL-C testing? In the last 2 years, Amgen's really sought to help thousands of people, knowing that just getting tested is the challenge. The website, it's called attackheartdisease.com. And in fact, it's a website that anyone can go on and that you can actually receive like a free LDL-C test, either shipped to your home, or you can also, if you choose to, you can go to a local clinic, have your physician order it for you. And so by doing so, it just informs yourself, your peers on, oh, I got my LDL-C test. I know what the level is now. Maybe I should get that, some actionable next steps. And so I'd say raising awareness. And, once an individual has that understanding of, this is a challenge, LDL, and this is what I'm doing to combat that, share that across your peers, distribute educational resources that are simple. And from that perspective too, ensuring that you invest, I think we touched upon this as well, like culturally and linguistically tailored material and campaigns around all of our disease states. So for myself, it's LDL-C testing and management, but for others, I think it's so important just to meet patients where they are. And just touching lastly on the advocacy piece, like I shared, step therapy, prior authorizations is such a challenge. So from, like you shared, Dr. Srinivas, I think there's like so much impact that can be had at that local level. So encouraging, Congress to adopt, policies, legislation that is like reasonable. So reasonable prior authorization, reasonable step edits that would allow for that timely care.
Great. Thank you. All right, Adam, you're up for funding and some of the solutions.
Yeah, absolutely. So I think right now is the time to really let policymakers, both in government, but also out of government, whether it's through philanthropy or private enterprise, understand that now is the time to invest in health and health programs. We've seen a lot of investment over the last several years that is at threat to being cut, and doing so would really jeopardize the progress that we have made. So I would say a couple of things. First is underscore the importance of whatever the health issue is to your community, to you specifically, to you and your families, contact your elected officials and let them know why that program is important to you personally and to your community. I used to work on Capitol Hill, and one of the things I used to tell constituents and individuals visiting the office is that yes, policymakers and congressional offices in particular are inundated with individuals trying to get their foot in the door and explain their positions. But for every person that we would meet with, there are so many others who never have their voices heard. And right now we're in a position where we need to have all of our voices heard so that individuals, those making these policy decisions, really understand the importance of the various programs, whether it's Medicaid, whether it's other federal benefits programs, whether it's the Affordable Care Act and other programs, why those are important to continue to invest in, and that cuts will be detrimental to individual health. Second is that investing in data disaggregation, ensuring that the federal agencies and cities and states collect this disaggregated data, and that's going to require investment. We know that it's going to cost money, but the money that it costs will pay dividends in better understanding how specific diseases and other health issues are affecting specific communities, and how is it that we can target interventions to be more efficient with the dollars that are being spent in the healthcare system. Similarly, investing in language access, like I said before, like when individuals are able to get information in a language that they can understand, they are more likely to adhere to protocols, and they're more likely to have more frequent visits and to visit their doctor so that they can really delve into preventive treatment versus getting it coming in when it's already too late, and emergency room visits or others are way more expensive. So that is important. And also invest on the provider side, having investments in ensuring that healthcare providers are providing that language access assistance. For APAICSO, that means investments in a multilingual workforce, ensuring that the providers that patients are seeing do speak a language that they can understand and that they're able to communicate with. It's something that many of our members do so well by hiring individuals that speak the language of the communities in which they're rooted. And we think that's important just not only from a direct communication, but also in providing translated materials and interpretation services when people come through the door. And lastly, the investments that we make now, I think will pay for themselves and ensure better health outcomes for our communities, and making sure that our communities really receive the care that they need, that they deserve, and that they're entitled to when they're living in the United States of America.
Thank you, Adam. Liam, why don't you talk about funding and just some of the issues, how to combat that?
So I actually work both in a pharma company as well as a hospital as an adjunct faculty. So vastly similar themes this year, I would say, right? Funding challenges exist for pretty much every organization in the US right now. And a biopharma perspective, it's really about making sure that every dollar is spent towards advancements that benefits individuals of all races and ethnicities, right? And again, that comes back to being intentional and recognizing the disparity. So I'm actually really genuinely excited to be at AstraZeneca because we're actively addressing some of those gaps that I discussed earlier about lung cancer disparities for Asian American community. And we're doing it largely through our co-founding role of the Lung Ambition Alliance as an example of an initiative that we're running. So this is a global coalition started in 2019, focusing on eliminating lung cancer as a cause of death, right? And it's a bold ambition for sure, but through this alliance, we've been able to support different types of equity solution. And so, for example, raising awareness on the importance of lung cancer screening through community engagements and really working with community leaders in particular to deliver culturally relevant education that would resonate with those patients, right? As well as sponsoring patient support programs. And that goes to language-specific services that we talked about so many times before now, right? Language and culturally sensitive information, and delivering that through the care support systems that we are sponsoring, we're able to sort of close those gaps as well. And then emphasizing equity in medical research, right? Obviously, as a biopharma company, we conduct a lot of clinical trials, and we've talked about that point. Our AZ R&D and medical leadership actually published an article last year analyzing about 12 years worth of clinical trial data from US that shows that overall we're doing pretty well when we're comparing representation to the US Census. But Asian Americans in particular, we came in at 1.8% representation in our trials versus 4.8%. And we outlined how we're aiming to do different types of initiatives to close that gap further, right? So being intentional is really key when we're talking about closing the gap. And I want to just end it here with particular efforts that we're doing for Asian Americans. So, for instance, we're collaborating with Jeff on female Asian never smokers as a study concept for screening. And Jeff, if you wanted to just elaborate on that briefly before we kick it over to another panelist.
Liam, I wish we had more time, but yes, absolutely. Are basically combining our efforts over at Kaiser, looking at a screening study where we don't have guidelines right now for these Asian American women, right? Because they don't smoke, but they get a lot of lung cancer, right? So bottom line is there is some data out of Asia that there could be benefits of screening these women that don't smoke, but that the government are not going to get data for unless we start something and do something. And right now we're looking in combination with AstraZeneca is to screen these women, just particularly not just screen any Asian woman off the street, right? That doesn't smoke, right? That's probably not high yield. Like what Liam said, you want to be focused and get the highest yield, most bang for your buck per se. And that is Asian women over a certain age, usually in the 40s to over 40 or 50 years old, that have a family history of lung cancer. And so we're going to be screening these women because we know based on data from Asia and Taiwan that you do have an increased risk of lung cancer regardless of smoking. So if we can show that similar data, maybe we could change policy, right? And get Dr. Srinivas and groups to start funding more studies to say, hey, maybe we should broaden in certain select at-risk, meaning Asian American groups of screening these individuals because they're inordinately getting diagnosed more with stage 4 lung cancer and not stage 1 lung cancer. So that's one way of kind of speaking, getting the dollars for a certain group, even though we know it's kind of limited. So Jenifer, why don't you go ahead and describe kind of maybe some of the funding issues that your group may have and how do you combat that and how do you win that over?
Thank you. And I'm sitting with Dr. Lee over here because I'm thinking a little bit about my own family stories of the Asian communities and those that have had lung cancer. And so we didn't talk a lot about the patients themselves in this conversation, but certainly, of course, you probably all of you can think about patients that resonate with this data that we are talking about here. As far as the RDDC goes, right, as a patient advocacy organization, we are a nonprofit. And so the funding piece, I think, is multi-pronged. On the one hand, we advocate for, because we've got that policy arm, that the CMS, the Center for Medicaid, Medicare Services, we all know what's been happening over there in the current administration. And when we look at it through the lens of rare diseases, and we look at the way the insurance companies take a nod in the way that the schedules are done over at Medicaid, for example, it's highly impacted by the rare disease community. So, that is a problem, right, in the way that CMS is handling rare diseases. What are the therapeutics? Sickle cell and the way that the new treatments are happening for sickle cell, which can be so expensive, is something we've been all keeping our eye on with the opportunities there for the Medicaid component to it. So that's an opportunity, and that's something that we continue to be concerned by the type of rare disease treatments that we have, because the FDA has only had therapy for 5% of these 10,000 rare diseases. So it's a huge issue. So we encourage the FDA, the NIH, continue to do that research in those areas of rare diseases. I also want to say, because when you think about funding and the way that the coalition is made up as a nonprofit, we also work really closely with the biotech pharma companies. And when we have the stock market that's so volatile, and that impacts the way that they're operating and how they're going to be spending some money and partnering with patient advocacy organizations, that's another component when you talk about funding. So in all these different headwinds that we've got going on with RDDC, for example, what are we doing? We've got the opportunity now that we've been around for almost 5 years to actually do a debrief on the Hill, which we will do in April. So we're going to share some of the data I mentioned earlier in the inequities in the rare disease communities with folks up on the Hill. So we'll be there in April. That'll be the first time we're doing our own Hill briefing out there so that we can continue to build upon these relationships that we've been doing the last 4 years. We're going to go ahead and, aside from getting some of this documentation published, take the opportunity to encourage our colleagues in the space and to find more folks, quite frankly, in the Asian community to speak up, because we're doing a National Minority Quality Forum rare disease track also in April, because April is also National Minority Health Month. We want to be sure that we're getting the representation, because that matters. And there's not a lot of people that look like me, that look like you all, that are out there advocating in this space in the rare disease community. So I think that's another big both opportunity as well as just the realities of what's happening in the rare disease community. So we're here at RDDC to help in that space and to be a solution so that we have more voices out there. So all these things that we talked about, it's not just of a level of awareness, but a level of comfort, so that we are helping them change a little bit of their culture as they're living here in the United States.
Great. Thank you, Jenifer. And last but not least, Dr. Srinivas, your thoughts on funding issues and how we combat that. Thank you.
everybody's touched on so many different aspects of how it's influencing access to care for patients. And I have to ultimately admit, I agree with every single person. I'm very concerned. Everything from the Medicare and Medicaid cuts to the pause on research grants. These are going to impact directly patient services. So with my doctor hat on, I'm very concerned from that standpoint. With my physician researcher hat on, I'm very concerned with the NIH pauses, what's going to happen to the future generation of physician researchers? Are we going to have this massive gap in advancement that we have been lucky enough to experience over the last few years that have enabled us to get better cancer care, better care for kids who are battling from rare diseases, better care for infectious diseases? Are we suddenly going to have a hiatus when it comes to this? And those techniques that get passed on from generation to generation, what's going to happen to those? And so that's what I'm concerned about in that hat. But then I look at it from a policy hat, from being a representative, and I'm thinking, okay, I've got 33,000 constituents in my district, many of whom are going to be impacted one way or another, whether it's going to restrict their access to care or even just their access to information. When we're seeing bills going through, such as one that happened here in Iowa, or that's in the process of being worked on here in Iowa, that are all trying to attack DEI, they're not understanding the true concept of what DEI encompasses. One bill in particular, for instance, said that no medical faculty could be affiliated with any of our universities if they discussed DEI issues. That impacts our community in so many different ways. It impacts the rural-urban divide, that's DEI. It impacts our AAPI divides, but it also impacts people in ways that they don't understand. And so one thing that I've often tried to do with my legislators who have a few different values than me that propose some of these ideas is try to relate it to how it's actually going to impact their life, because there's just so much misunderstanding. And so one of these bills, that bill in particular, I was able to kill by being able to tell them, you're telling an OBGYN that they can't say that a female patient has a higher risk of cervical cancer now, because that's acknowledging a difference that would be falling under DEI. So really trying to share with them ways in which their legislation impacts patient care, even if it's not what they envisioned, that can really put pause on some of these negative solutions. One of the things that's happening with our current administration is also this additional pause on well-established guideline organizations like ACIP, who come up with these guidelines that help us deliver better care to our patients, to our community members, and even help each of us get better care. This opens the door for having to find an alternative to creating those same conversations. So this is a time when we can look at our patient advocacy groups, our established professional societies, and use them to partner with. And it also creates an opportunity then at the state level to inject more of these changes that could be positive for our communities, as the federal side is getting a little bit more lost in the haze, I'll say. And so we can't just look at that and be purely worried. Instead, we have to look, as many of you have highlighted, the solutions of other ways in which we can get at still helping these same communities. And sometimes, honestly, working at the state level is a lot easier than working at the federal level. As Adam alluded to, there's always a long line out the door on Capitol Hill. At your state level, it's going to be a lot easier to get that access and make that change happen. So as we have more emphasis being done on what can be done at the states, this is an opportunity really to advocate for your patients. And sure, you're going to have to do it in 50 different states. But once it goes into place in one state, and we say that about all different types of policy, it's really easy to use that as a precedent to create change that ripples through other states then too. Legislators are very open to copying what one other state does if they're seeing effective outcomes. So we can utilize that to really create better conversations that have been restricted given the new administration. So I'm optimistic while I'm still have concerns, and we have to go into it with eyes wide open, knowing the restrictions that are in place, so we can find other ways to work together to make sure patients in our community really get the service they need.
Thank you, Dr. Srinivas. That's perfect. So that's a nice concluding statement. Thank you to our esteemed panelists, and good afternoon.